Imagine stepping into a medical crisis where a patient is profoundly vulnerable, her family is openly warring, and the healthcare system itself seems, well, overwhelmed and fractured.
Yeah.
This isn't some TV drama, though it sounds like one. It's a real-life case study with extraordinary lessons. Today, our deep dive, using excerpts from Navigating Frailty and Family Conflict, A Geriatrician's Triumph, is all about unpacking how a medical emergency can just spiral into an ethical and legal minefield.
Right.
We'll explore how one specialist's dedicated, really holistic approach turned an almost impossible situation around.
It's a fascinating case.
Yeah, and reveals some surprising truths about treating the person, not just the disease. Let's get into it.
Okay.
So let's start by really immersing ourselves in the patient's circumstances. She was elderly, profoundly frail, diagnosed with a very aggressive neck tumor.
A really serious diagnosis on its own.
Exactly. In her daily life, assisted living, relying on a walker, multiple falls in her history.
So baseline vulnerability was already extremely high.
Extremely. And crucially, she had moderate to severe dementia.
Okay.
Which meant, while she might understand, I have cancer, grasping complex treatments, risks, benefits, that wasn't really possible for her. She couldn't truly participate in informed decision-making.
That complicates everything from the start, doesn't it? Informed consent is, well, it's a huge issue there.
Absolutely. And add to that, a history of heart valve problems and blood clots, DVT and PE.
Wow. Deep vein thrombosis and pulmonary embolism. So serious clotting risks, too.
Yeah, layers upon layers of risk for anything invasive.
Indeed. I mean, this isn't just complex medically. It's a profound ethical and clinical dilemma right out of the gate.
Right.
When you have that level of cognitive impairment, the standard medical playbook,
Right.
you often have to just rethink it radically.
Oh, it does you too, yeah.
It really demands a holistic view immediately. Balancing aggressive treatment with quality of life becomes paramount.
Okay, so that's the patient. Now, layer on the family dynamic. This quickly became the central source of just extreme conflict. Two children. One, a medical professional, was pushing hard for surgery. Very focused on cure the disease itself.
Very disease-oriented approach, yeah.
Yeah.
Common in medical training sometimes.
Right. The other child, not in the medical field, was just as strongly against surgery, terrified about what it would do to her mother's cognitive state, her function.
So completely opposing viewpoints on the core treatment.
Completely. And their interactions were described as being on the verge of killing each other. Literally.
Wow.
One child crying, the other yelling. I mean, can you imagine trying to have a goals of care discussion in that room?
That kind of intense conflict.
Yeah.
It doesn't just complicate planning, it can actually sabotage it.
Sabotage it, exactly.
It paralyzes any straightforward path. Every decision becomes this huge, tense negotiation.
And just when you think it can't get more complex, there was this secretive change in the healthcare proxy.
Oh boy.
For years, the doctor child had been the proxy, designated.
The one pushing for surgery.
Yes. But about a year earlier, while the patient's dementia was already progressing, she signed new documents making the non-medical child the proxy.
While she had progressing dementia. That's very tricky.
Very tricky. And her stated reason, reportedly, was she felt her doctor child might not have her best interest in mind because the child is a doctor.
That's a fascinating and worrying statement.
Isn't it? And the doctor child had no idea. Completely unaware.
Worrying sighted.
Totally. The non-medical child, who apparently had been somewhat estranged for years, just produced these documents at the initial consult.
Wow. Estrangement adds another layer. This is a legal and ethical minefield.
Right.
Absolutely. It throws you right into the deep end of autonomy versus capacity with dementia. And that timing, the estrangement, it really raises questions about how autonomous that proxy change truly was.
But how do you navigate that fairly? It's incredibly difficult.
Extremely.
So amid all this, what was the initial medical plan? It was daunting.
Let me guess. Pretty aggressive.
Very aggressive. Multimodality, surgery for the tumor, complex plastic surgery for reconstruction, followed by radiation, and then maybe chemo or immunotherapy.
Wow. That is a lot. Especially given everything we've just discussed about her frailty and dementia.
Exactly.
Yeah.
The geriatrician involved later noted this plan would be overwhelming for a healthy 40-year-old.
Let alone this patient.
Right. This kitchen sink approach, as the source called it, understandably terrified the family, especially the non-medical child who was now the proxy.
And this really highlights what the source called the disconnect from reality from those initial teams.
Yeah, that phrase stood out.
It seemed like they were just treating the tumor, not the patient. Despite her obvious frailty, the dementia, the family chaos, the plan was purely disease-focused. Like, as the source put it, nobody was actually paying attention to the patient at all. They did not see the patient at all.
Such a powerful and sad observation.
It really is. And that failure to see the whole person, her actual condition, her likely goals if she could express them, that's exactly why the geriatrician's intervention became so crucial.
Okay, so let's talk about that intervention. This is where things really take a turn. The geriatrician didn't just, assess frailty and write a note.
No, they didn't just punt it back, as sometimes happens.
Right, they took ownership of the chaos. We're talking an estimated 20-plus hours spent on this single case.
20 hours? That's a huge investment of time.
Huge. Lengthy phone calls with both kids, separately. Managing unannounced emotional clinic visits for them.
Oh, I can only imagine.
Constantly explaining the tangled family dynamics to social work, patient reps, who were apparently slow to grasp just how bad it was.
That kind of coordination and mediation is often invisible work, but absolutely critical.
And they actively pushed the other medical teams, pushed them to convene a proper tumor board, insisted on a sequential, one-step-at-a-time plan, not the everything-at-once approach.
So acting as a central coordinator, a brake pedal.
Exactly, trying to stop the whole thing from imploding. They really became, like, the shock absorber for the whole system.
That's a great way to put it. And, this proactive role immediately ran into the existing problems, the significant communication breakdown, and poor inter-team dynamics the source mentioned.
So the geriatrician had to navigate that too.
Absolutely. Can you believe this? Right after a 2-hour meeting the geriatrician had with the warring children, painstakingly going over surgery risks and benefits,
Yeah.
the surgeon sends a text message? Just a text, saying they were now extremely in favor of starting with immunotherapy.
Wait, a complete reversal after the meeting via text.
Exactly. A total flip from the prior surgical push, communicated incredibly poorly. It shows the tension.
Wow.
There were clearly teams pushing others, trying to get alignment. Eventually, emails went out basically saying, we're doing immunotherapy, back off pushing for surgery right now.
So the geriatrician's push for a considered approach, and maybe the tumor board, led to immunotherapy.
It seems that careful deliberation, driven by the geriatrician and the tumor board, shifted the focus, and immunotherapy became the chosen first step.
And how did that go?
Remarkably well, actually.
Really?
Yes. The patient tolerated it well, minimal side effects, and after just 2 cycles, the visible tumor on her neck had substantially reduced in size.
It's a fantastic clinical outcome.
It is. But it's more than that, right? It validated the entire approach.
How so?
It showed that the less aggressive, more patient-appropriate path the geriatrician fought for worked. It demonstrated the power of tailoring care instead of just throwing the medical encyclopedia at her.
A huge win for that approach. But the family conflict didn't just vanish, did it?
Oh, definitely not. Even with the good clinical news, things boiled over.
What happened?
The non-medical child, the proxy, apparently had a major outburst.
Oh, dear.
Yeah. Yelled at, cursed at some team members. The trigger seemed to be repeated scheduling and canceling of appointments, which can be incredibly frustrating.
Understandable frustration, but still, that's not good.
Not good at all. It got to the point where the hospital's legal department had to get involved.
Legal?
Yeah, to de-escalate, to manage the daughter's interactions with the staff.
So the conflict became unmanageable for the clinical team alone.
Completely. And interestingly, the source notes the doctor-child only stopped aggressively pushing for various invasive procedures after legal got involved.
So the legal intervention might have finally put a check on that pressure.
It seems that way. It really underscores how extreme the psychosocial complexities were, basically hijacking the medical care until an external authority stepped in.
It brings us back to that idea you mentioned earlier, the geriatrician as a shock absorber. The source used another metaphor too, didn't they? An airbag.
Yes, I love that metaphor. It's so apt for geriatrics.
Explain that a bit.
Well, the idea is you can't always prevent the car crash. Sometimes a poor outcome is unavoidable given the circumstances.
Right.
But the geriatrician's role, like an airbag, is to deploy, to intervene, and make sure that the damage is going to be very limited.
Damage control. Minimizing harm.
Exactly. In this case, by steering everyone away from that potentially devastating surgery towards the less harmful immunotherapy, they cushion the impact. For the patient, certainly, but also for the family, despite the conflict.
It protected everyone from the worst potential outcome of that initial aggressive plan. A perfect illustration of the airbag deploying.
It really is. And this case perfectly highlights a core challenge in geriatrics: the difficulty of quantifying value.
What do you mean by that?
Think about those 20-plus hours the geriatrician spent. Mediating, coordinating, advocating, managing those emotional visits, countless phone calls.
All that invisible work.
Precisely. That work averted a likely medical disaster, probably an ethical nightmare, maybe even legal action down the line. But how do you put a number on that? How do you bill for preventing a catastrophe?
You can't, really. In our current system, procedures get valued, but prevention and coordination.
It's much harder. It's often unseen, unmeasured by the system's usual metrics. And that raises a huge question for the field. How do we better demonstrate this immense value? The value of preventing suffering, preventing terrible outcomes. That is the essence of high-quality geriatric care.
So wrapping this up, what does this incredible case really show us?
I mean, for me, it powerfully demonstrates the impact of a truly patient-centered approach, especially when things are this complex: frailty, family war, a fragmented system.
It's about seeing beyond the tumor, right? Seeing the whole person, their life, their situation.
Absolutely. And seeing how that focus can completely change the trajectory, change the outcome.
That dedicated advocacy, that thoughtful coordination, even if it's hard to quantify, it really can be that airbag.
It truly can save a situation from disaster. It's a strong reminder that sometimes the best treatment isn't a scalpel or a drug,
but profound holistic care, listening, coordinating, mediating.
Exactly, the human element.
So, maybe a final thought for you, our listener, to consider. How often does this invisible work, the coordination, the empathy, the human connection in healthcare, how often does it prevent silent disasters we never even hear about?
And following on that, what systemic changes might help us better recognize, support, and value that absolutely crucial work?
Something to definitely think about.